PDA Video 1. Hello everyone, welcome to NEFCO YouTube channel. Today we will be discussing a case which normally we go through in our NICUs. This is a case of a preterm with a PDA. But why I want to bring up this case is that when we decide to treat or when we decide whether we can leave this PDA and wait and monitor the PDA. So this is preterm baby, 27 weeks, birth weight was 930 grams. Now this baby is 30 days old, corrected almost 31 plus something, like 32 weeks gestation. We ventilated this baby for 48 hours, given surfactant, and then we extubated on CPAP. And now today this baby's weight is 1.2 kgs. She is on NIV, DOPAP with FiO2 of 21%. So initially on the day 1, within 24 hours, PDA size was 0.6 millimeters. At that time baby was on ventilator. So at that point of time we decided not to treat this duct. On day 3, when we extubated this baby, the PDA was becoming HSPDA. So size increased to 1.6, 1.8 millimeters. So that point of time we started with the IV paracetamol. The PDA size slowly decreased. It came down till 1 millimeter and became non-HSPDA. So after 7 days we stopped with IV fipronil. And then slowly the respiratory support also went down. But for the last few days this baby is on DOPAP and FiO2 of 21%. But this PDA, we are just monitoring this duct. This PDA size started from 0.6 millimeter, went up to 1.6. We started the treatment, came down to 1. We stopped the treatment for 7 days, and then still then we are monitoring. And today this baby is 30 days old. No medical treatment of the PDA is being done. 21% DOPAP. And today echo, I will show you the views of the duct and few of the features and indices. The duct is around 2.2 millimeters, so it has increased. But even then, at this point of time, there are no other features of HSPDA, and we have kept the duct alone. We are not treating this duct at the time, for the time being. Pause. See, this is LALV. It is very much dilated as compared to RARV. So we will just do LA ratio. You see, I have brought this cursor just below the mitral valve in the red jet for E/A ratio, pulse wave Doppler. As you can see, E/A ratio is now 0.8, which was high. So that may, even though because this was HSPDA, LALV is dilated, but E/A ratio is 0.8, which is normal for the preterm babies. It is not high. If this would have been more than 1 or 1.2, it would have been significant. This is the ductal view, pulmonary artery, descending aorta, and this is from the descending aorta. Very nicely you can see this PDA going up. If I put a color, you can see this red jet, left to right shunting. This is your PDA. This is the PDA. This is where it is entering. So it is around 2.3 millimeters. Left to right shunting. I will show you the Dopplers of this duct. I put the cursor within the body of the duct. And this is all left to right shunting. And when I look for the peak systolic flow in this, it is around 3 meters per second. So that is showing it is a restrictive PDA. Even though this size is 2.3 millimeters, but there are no features, other industries that are suggesting it is HSPDA. It is showing it is restrictive PDA, 30 days old baby. We have already treated with one course of injection fibrinil, but now the baby clinically is becoming better, gaining weight, tolerating feeds, and there are no features of hemodynamically significant PDA, so we have left this PDA alone. So that's how with point of care ultrasound or functional echo we can look and monitor the duct, and we can intervene when needed, and when it is not indicated as per the indices, we can stop the treatment and we just monitor the duct. Thank you.